afternoon, everyone, and welcome to today's Public Health Ontario Microbiology Rounds presentation on the implementation and application of next-generation sequencing of SARS-CoV-2 in British Columbia. My name is Roberto Melano, a scientist at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin with today's presentation, I'll mention a few housekeeping items. The chat pod has been disabled to limit any distraction during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issue, please email capacitybuilding@oahpp.ca. I would like to state that as the moderator of this session, I do not have any potential conflict of interest to declare. It is my pleasure to introduce the speaker for today's presentation, Dr. Linda Wang. Dr. Wang is the Associate Director of the BCCDC Public Health Laboratory and Program Head of the BCCDC Public Health Advanced Bacteriology and Mycology Program, a medical microbiologist and clinical associate professor in the Department of Pathology and Laboratory Medicine at the University of British Columbia. She is the medical co-lead of BC's Provincial Infection Control Network, PICNET. Her team at the BCCDC PHL rapidly ramped up next-generation sequencing capacity to support the COVID-19 pandemic response. Dr. Wang's pre-COVID-19 clinical and research interests is really broad, including containment level 3 pathogens and agents of bioterrorism, healthcare-acquired infections, antibiotic-resistant organisms, Cryptococcus gattii, enteric bacterial pathogens, and other bacterial outbreaks in British Columbia. With this short intro, please join me to welcome Dr. Wang. Linda.
Thanks, Roberto, for the kind words. And thank you so much for the privilege to speak to you all today and share with you our experience here in British Columbia. So I struggled with what to present today. I thought I would present to you essentially the work that I've been doing along with a very large team that grew rapidly during the course of the pandemic, and that's in the implementation and application of next generation sequencing of SARS-CoV in British Columbia. So I want to start out by declaring that I have no conflicts to declare. The objectives for today are to identify the role of SARS-CoV in the different phases of COVID pandemic in BC. I'll give you some examples of how we use genomics to support public health. But more importantly, what I'm going to focus on today, that is sort of the foundation of our talk, is to share with you how we approach the operationalization of genomics in a public health laboratory, such as the BC Centre for Disease Control Public Health Laboratory. So if you guys can all remember the time before COVID, and if we reflected upon that time, at the BC Centre for Disease Control, which is situated in Vancouver on the west coast of this country, we had started to explore genomics work in a very limited role and with some capacity, mostly supported by research, external collaboration. And the background for that is certainly as a public health laboratory in Ontario, you folks also understand, appreciate the importance and significance of strain typing methods. And historically, as a public health lab and a foundation of what we do, strain typing is very important and bread and butter for us to support outbreak investigation, emerging pathogens, as well as multi-drug resistance and various other characteristics of microbial organisms using conventional methods such as PFGE, RFLP, MLST, biotyping, etc. And so the question then is, why do we perform subtyping, or also referred to as fingerprinting by our public health and our epi colleagues? And this is really, there's three reasons. One is to support outbreak response, to confirm epidemiological relationships in the spread of disease. For the purpose of cluster detection, providing our epi colleagues and public health folks hypotheses about the data, epi data showing relationships or absence of relationships between the different metadata components. And then thirdly, of course, is the surveillance. How are these pathogens distributed across the population of interest? And so not all methods are equivalent, and some methods have certain attributes while others may be lacking those attributes. And so the attributes that we look for to identify an appropriate fingerprint method are those that have a strong discriminatory power, is relatively rapid to use to generate data, is inexpensive to perform, easy to perform such that it can be operationalized by technologists that we have access to, highly reproducible, so important from a quality standpoint, and that can be standardized with a nomenclature in order to interpret to our end users and our clients. And so in this day and age, genomics is essentially the most optimum tools that we have. So the brilliance and the vision of our PulseNet Canada colleagues initiated the conversation and the operationalization of PFGE into whole genome sequencing back in 2013. Selina Dunn and her group came up with this roadmap that really paved the way for this country to develop the groundwork for genomics in our public health laboratory. In addition to that, in British Columbia, we had also, through external grant funding, implemented routine whole genome sequencing of all carbapenemase producing organisms that were identified since 2008. And we had initially attempted using conventional methods such as PFGE, but with the complexity of plasmid-mediated transmission within different types of organisms, it was clear that conventional methods was not going to work. And so the transition to PFGE to whole genome sequencing, not at the research capacity, but at an operational capacity, was really what we had set off to do about a decade ago. This required new skill sets, infrastructures, technologies, and also standardization of nomenclature and intense discussions with our public health colleagues to inform and educate our end users on how to use the information. Technology was extremely challenging. They were expensive and so often initiated by research funding, but our public health laboratory and PHSA had stepped up to support us with some of the infrastructure upgrade along with external funding opportunities. And so this all started out, the operationalization started out with CPO work supported by our Enterix Pulse network, where we created a workflow that allowed for identification of the cases, running them through the genomics ways, and then creating standardized reporting and communication with our end user. And this is going to be a common theme throughout this talk here. And so we quickly realized the complexity of this. It was not easy. The laboratory that is set up for conventional microbiology, even with molecular work, was not well equipped to do genomics. The need for lab information management and integration tools, genomics pipelines, nomenclature standardizations, and collaboration with the health authority facilities, as well as provincial public health and health authority for public health was really critical. And this inspired us, and we recognized that our end users did not have ready access to the data that we were generated, and our LIS system, our laboratory information system, was not well equipped to provide our end users with the appropriate information. And so we created an integrated data access tool called Plover, which allowed our health authority, at the health authority level, to be able to access case data and as well as genomics data. And so Plover also refers to a bird, but stands for Public Health Lab Operations Data viewer, and reporter. And this tool allowed integration of laboratory data as well as metadata and made those accessible to our health authorities in a controlled and protected environment for line level access. So in terms of capacity in 2009, from a genomics capacity perspective, we were sequencing about 24 samples a week. And again, a combination of PulseNet and carbapenemase producing organisms. Many were grant fund, much of our funding was from grant, both provincial and federal grant sources. We had very limited operational capacity, very limited bioinformatics capacity, limited data integration capabilities, and very limited ability to interpret and report our genomics results. And so it was necessary for us to pursue ongoing research collaboration in order to build on some of those capacities. And then COVID hit. And so in the early days of COVID, as many of you remember, December 2019 was when an unknown type of pneumonia was identified and reported from Wuhan. Pneumonia of unknown cause was then reported to WHO by the end of December 2019, and the lab confirmation of 41 patients was reported in early January. By January 9th, there clearly was a cluster of pneumonia cases reported by WHO in Wuhan, China, and by January 10th, 2020, the entire genome of this coronavirus was reported publicly and accessible to all. And this was really historical, and it's never been done before. And so in British Columbia, following the release of the genome of the 2019 nCoV, as it was called at the time, within 10 days, we were able to develop qPCR in British Columbia, and that was undergoing validation with the first positive sample identified in first person under investigation identified in January 27th with our first positive sample on February 2nd. And so this was primarily based on the publicly available whole genome sequencing data, which also informed us that this is a novel virus, was about 80% related to SARS-CoV-2, and the closest organism that's ever been sequenced was from a bat that resides in a vicinity or a cave close to the Wuhan area. And all of this work was done without ever having to harm a single coronavirus. So without any culture-based work, without any conventional work, purely genomics-based work was used to support this, the advances from the diagnostics perspective. So how is genomics used for COVID-19 then? As you all know, whole genome sequencing provides the molecular fingerprint or genetic material for the entire organism. And I'm sure you're all also very familiar with its applications, such as for molecular assay design, cluster outbreak investigation. It's also been used to identify drug susceptibility and resistance, virulence factors prediction, detecting new variants, and vaccine design and development. And we certainly have seen that over the course of this pandemic. And this is a graph showing the date on the x-axis, on the y-axis are the number of cases. And you can see here that there, during the early days of the pandemic, BC was the first to identify cases from Iran that were positive for COVID. And at the time, Iran was not identified yet as a source, as a country with COVID transmission. But we were starting to see travelers from Iran. We were seeing travelers from many countries. But what was really significant was in the early days, a significant proportion of our transmission in our community was associated with cases that had traveled from Washington State, and then this particular lineage ended up in our long-term care facilities and transmitted there. So outbreaks from our long-term care facilities originating from returning travelers from Washington. Also around that time, there was a large dental conference in British Columbia, before all of the measures and travel restrictions were put into place. There was a dental conference, and many of these hosted attendees from many European countries, and that was the initial seed of our B1 lineage into British Columbia. Genomics was also used in many situations to support outbreak investigations, both at the community settings as well as in the acute care setting. So this is an example of a large cluster within an acute care facility where it wasn't clear whether the cases identified in wards A and ward B were related. There may have been some epidemiological overlaps, but it wasn't clear whether these cases were genomically related or not. And based on this phylogenetic tree here, you can see that the cluster above in green was associated with ward A, whereas the cases that form the cluster below in red are associated with ward B. And through the use of genomics, it really informed infection control on how to pursue and investigate and manage this outbreak. And more recently, actually from the beginning of COVID time and until recently, we're able to look back and review how the different lineages have emerged over time. And you can see here the role of genomics for surveillance purposes and monitoring of the different lineages. And I haven't added Omicron to this yet, but you can see how, in British Columbia, as well as across the world, that the Delta variant has taken over all the lineages that we've seen previously. So what drives our genomics use and application is our collaboration and regular communication with our public health colleagues. The public health use, the end users' need for this data to inform and support their work is really the motivation for us to do whole genome sequencing in a timely manner. And so for the purpose of provincial surveillance, outbreak investigation, targeted surveillance populations and projects such as following pediatric cases, travelers, and then cases of reinfection. But this needs to be balanced against the laboratory genomics capacity and also the value of the information. Generating genomics data for the purpose of interest and curiosity doesn't justify the intense amount of work and resources that are being poured into this work. So by late January, as you recall, there was a world distribution of COVID worldwide, and we start to see different lineages emerging as well. And shortly after are the emergence of variants of concern, as you can see here, and I'm sure you're all very familiar with. And of course, then this led to, well, how do we detect these variants of concern while whole genome sequencing is still taking a week and a half, 2 weeks to generate? And we needed to do something faster. And so based on in silico data, qPCR for these variants of concern was developed and implemented. And this is an example of how we had implemented the strategy of screening for VOC and then whole genome sequencing a proportion of those based on the importance of the different lineages. And before you know it, and I'm just going to essentially demonstrate to you that before you know it, different lineages had emerged very rapidly, and to be able to keep up with that was not possible. This was our sequencing strategy in the early days for whole genome sequencing. So we started with screening for VOC. The presumptive VOCs are reported out for public health, and a proportion of those were then put into the workflow for whole genome sequencing, as well as a proportion of the non-VOCs were also entered into the workflow for whole genome sequencing. Alongside that are the priority organisms as well as baseline surveillance. So about 600 a week were also added to the workflow for sequencing. And you can appreciate how complex it is to have to sort and manage these different buckets for sequencing and reasons for sequencing. And so by the end of August, we had, so by February, we had sequenced over 5,000 COVID genomes. And the number and the volume of data was getting unmanageable. We were still using Excel spreadsheets to handle this. And we were able to look back and see the different surges over time. And so by March here, our volume had increased substantially with a combination of influx of new lineages from international travel, as well as local transmission. And so how are we to handle all of that? And the VOCs were no longer effective because there were emerging lineages over time that required us to have to monitor on a real-time basis. And so this graph here shows the distribution of the lineages over time in British Columbia by the color coding. So then we discontinued VOC screening and poured all of the whole genome sequence positive cases directly in, all of the COVID positive cases directly into whole genome sequencing. And fortunately, around this time, our volume had decreased so that it was manageable. But then we had to struggle with the whole challenge of how do we manage the cluster detection and report those out to public health. And so first of all, let's talk about how we handle the analysis of this. And so whole genome sequencing was used to support outbreak cases. You can see that in this example, cases that are clearly linked to each other and confirm the epidemiological information that was initially identified, or cases that were not initially identified as part of an outbreak. And so a laboratory identified cluster, which would then inform public health that something's going on here, you should have a look and see if this is significant. And so these are often the missing links or a potential scope of transmission that public health may not be aware of. And so this provided timely information for public health. And so I asked a number of our health authority colleagues to give us examples of where the genomics was provide value for them, and where it really provided value. There are three main areas. One was around school clusters. And they felt that, or the feedback was that through the work that we did around school clusters, that WGS helped confirm their epi understanding that most of these cases were community acquired. While there was some transmission occurring in school, that certainly was not the majority. And so this helped with their policies, their messaging, and their management of the communities with high transmission in the community settings that were bleeding into the schools. Factories was a big area and a big industry in BC as well as in Ontario. And so again, understanding the cases that were coming up positive in some of these factories, was it due to transmission at the factories amongst the workers, or were these due to transmission in the community that was brought into the workplace? And so the genomics data really supported public health in understanding what was going on in these various facilities and to implement the mitigation strategies. In the acute care setting, as well as in long-term care facility outbreaks, genomics, again, in a timely manner, was able to help refine and understand the management of cases through cohorting and provide guidance for the providers to move forward in handling increases in cases during the course of the period of the outbreaks. And so here's the phylogeny tree I was referring to for pediatric cases. And you can see here, many of the pediatric cases that was sequenced here until the end of October was scattered across all the positives and all of the different communities, suggesting that they weren't really clustering with each other, but were distributed across the population that they resided in. And when we looked zoomed into some of these clusters, it was really clear that some of these pediatric cases clustered within many adult cases, again, suggesting household transmission or community transmissions. And so in response to provide this information to public health, we had to be able to provide genomics data very rapidly, as well as in a timely manner, so that public health was able to respond. And generating genomics results 2 months after the outbreak was not very useful. And so our volume was increasing. We still had regular work to do. How were we able to operationalize this in our laboratory? So the transition from research to clinical. So having that research foundation and having some of the basic tools, having the techs somewhat trained for PulseNet and for CPO, having Plover at least in place for CPO, allowed us to basically pluck this entire infrastructure and propped it over to the COVID workflow. So Plover was immediately transitioned to support COVID work. We improved our workflow through lean processes, liquid handling to automate library generations. We requested additional instrumentation, continued with our training and recruitment of staff, and automation was really important, as well as integration with our data with epidemiological data. This allowed us to bring the information together in a much more rapid and automated way. And this was a very significant amount of work, as you all recognize. But the key here is to do it in the quality framework of an accredited laboratory, where we looked at pre-analytical issues, analytical issues, post-analytical issues, followed the structure that is very much the standard of a diagnostic laboratory. And so in order to do this, we needed the support of our operations. And I think if it wasn't for the support of our operations, this would not have been feasible at all. And so what does this look like? In British Columbia, at the BCCDC Public Health Laboratory, our clinical laboratory programs are shown here: bacteriology, virology, mycobacteriology, and others. And our end users are shown on the right in orange, our health authorities, our provincial health officer, primary care providers for the purpose of patient care, our provincial epi colleagues, as well as health authority, epi colleagues, and infection prevention and control in acute care facilities. And so the idea here was that our bacteriology laboratory, which I oversee, took the lead on this role, and we created a framework underneath these programs to allow for an operational process in order to generate genomics information to the end users. And this is broken down into 5 components. So research and development component, a wet lab component, bioinformatics component, data integration and analysis component, and interpretation and reporting component. And these 5 groups have to be continuous and be able to talk with each other. We were able to staff these different workflows with new staff and brought in new expertise, as well as automation where necessary in order to make this happen. And without this structure, I don't think we would have been able to do what we've been able to do. So I'm going to come back to this slide multiple times during the course of my talk. And so wet lab method validation and operationalization was the first stage for all of this. There was extensive validation of all components of our protocol, whether it's the liquid handling protocol, whether it's kits used for amplicon synthesis, library prep sequencing. Every aspect of the workflow had to be validated and then translated into operations under a quality framework. This would not have been possible without a separate validation and implementation and R&D program. And it also would not have been feasible without introduction of equipment and resources that was made available through our health authority very urgently. And so with the R&D folks doing the evaluation and the validation, it allowed the day-to-day operations folks to focus on the workflow. And so the R&D and wet lab, for example, happen in parallel amongst different groups, and so that you don't end up interfering on the day-to-day work. And so then the wet lab folks were able to pick up on the already standardized methods, were able to implement that, train the techs, to write the SOPs. We had to develop a pseudo LIMS system because there was no laboratory information management system that was off the shelf that would have been applied to us. So we sort of developed our own Excel-based logic to create a workflow and organize our staff, maximize on efficiency and feasibility, and created modular workflows. And the important thing to recognize is that the workflow is not linear. And so we were able to break them up and be able to work with the scheduling and the operations that was available to us. I mentioned capital a few times, freezers, huge influx of samples, thousands a day. We needed to store them somewhere. So there was an influx of freezers, liquid handlers, as well as sequencers. We had to decide on the platform for the sequencer, and because of the background work for CPO and the enterics, our staff had already been trained on Illumina, and so that was the logical platform to go with. And you can imagine with the amount of pipetting and volume that we were handling that this was not sustainable, and so we were able to bring on a number of liquid handlers to automate the pipetting. And as I mentioned, every stage had to be evaluated for quality assurance. And so this is just an example of some of the work that was done to ensure that the methods that we were transitioning to was successful under a quality assurance standard. And so our goal was to generate whole genome sequence data in as close to real time as possible. And some of the work that we were able to do was allowed us to push back on the time it took. So for example here, hands-on, so table 1 shows the quality assurance component between the original method versus the new method. And I won't go into details of the different methods today. And evaluating the savings. So in terms of time as well as cost. So the cost of library prep, for example, was reduced by approximately 50%, but where the value add was in the time. So hands-on time, manual time was reduced from over 4 hours down to an hour. And liquid handling time was also reduced significantly. So total time to completing an assay, was a fraction of what it was initially. And this was due to the magic of some of our bioinformatics as well as wet lab scientists to be able to bring in, to maximize workflow, lean tools, as well as kits in order to reduce our time to a third of what it would otherwise take to generate a sequence. So our initial workflow from the time of the diagnostic qPCR become available, or from the time the extraction was available to analysis was 5 days. And that wasn't sustainable and acceptable for our public health colleagues who needed this information on a more timely basis. And so the pressure was upon us in order to do so. And this, I'm just going to scroll through quickly here. We looked at size selection of pools to maximize that, looked at steps where we could essentially reduce a processing time. So library prep was significantly reduced. Amplicon synthesis and sequencing was also reduced with the use of additional equipments and liquid handlings and automation, as well as staggering of work shift, allowed us to generate up to 10 libraries a day. And so we were able to increase our sequencing capacity from about 750 genomes per week to over 4,000 genomes per week, with a target of about 5 to 7 days from the time the sample was received from the frontline laboratories. So whole genome sequencing. So what are the reasons for testing? And this is just to reiterate what I've said over, is for surveillance, targeting populations of interest, and monitoring breakthroughs and reinfections. And this was in order to support public health. And at the time, they were interested in severe cases, as well as meeting the needs of federal surveillance. So data integration at this time was really important, as well as generating sequence data in a timely manner. So while our federal recommendation was to sequence about 10 to 15% of our positive cases, by around this time, we were sequencing about 100%. Our throughput at the time was about 4,000 samples per week for whole genome sequencing, but our weekly cases was now jumping to beyond 5,000 samples a week. We were also running into challenges of storage. And also at this week, the Delta was emerging and was extremely clonal. It didn't really make sense at the time to continue with whole genome sequencing at 100%. So we proposed to our public health that we needed to modify this. We would still recognize their priority list of clusters and outbreaks and travels and hospitalizations, et cetera. But it didn't make sense to do 100% of our cases for the purpose of priority as well as surveillance. We proposed that for the purpose of surveillance, we would sequence 100% of one of the weeks of the epi weeks. So week one, the first week of every month the first epi week of the month would be sequenced at 100%, whereas weeks 2 to 4 would be sequenced at a convenient sampling of 10%, in addition to trying to collect all the priority lists. And so this was implemented towards the end of September because our volumes was increasing by then. And so this table here shows, on the top table here, shows the distribution of all of our lineages that are color-coded here. And so you can see in the early days in February, March, April, the different combinations of different lineages, VOCs that were being monitored. And by June, the Delta had emerged and was starting to take over. And so towards the end of, by mid-November, the majority, or essentially all of our cases in British Columbia was due to Delta. And we had, because the volumes had increased significantly, we had modified our sequencing strategy to the end of November, during which time it actually made more sense for us to revert back to sequencing at 100%. The time it took to sort and manage and pluck the samples into the different buckets was more time consuming than the resources required to sequence at 100%. So towards the end of November, when our numbers were dropping below 200 cases a week, we reverted back to sequencing at 100%. So this is a diagram showing the different lineages, how it emerged over time. And then the bottom graph here was our total number across time, supplement or overlaid with our different sequencing strategies. So VOC confirmation, sequencing all positives, the modified strategy with the 100% surveillance of the first epi week, and then now we're sequencing again at 100%. So the key messages from our sequencing work was that in early March, there was a codominance of alpha and gamma. This rapidly was replaced by Delta towards the summer. And towards the end of the summer, we were predominantly seeing a couple of lineages of the Delta. And as you all know, Omicron is now emerging and probably will overtake the Delta as we've seen it. So that was the wet lab. And so now we've got this genomics data and the lineages that are significant. How do we handle and operationalize and automate the bioinformatics work? So as you all know, bioinformatician is not part of a laboratory. And so bringing in bioinformatician, introducing the quality laboratory framework was a novel approach. And automating and being able to do that while automating the work and making bioinformatics accessible to our operational staff was really key. And so that was the goal. And so using standardized pipelines with the support of our bioinformatics scientists, we generated workflows that was operationalizable with basic SOPs, push buttons for our technologists to be able to handle. And the data that was generated allow us to look at lineages over time in real time as a lab-based surveillance of the different lineages. We also had trained our laboratories to analyze these data, to analyze the cluster data. As you can see here, this dendrogram, the lineages that was generated was looked at in the dendrogram and that they had to analyze the data. Oh, sorry, I just threw in this slide. I thought it would be fun to look at Omicron emerging in Ontario in early December. I'm sure you've seen this before. So this is from the GISAID international database with Omicron as the couple of Omicron in Canada originating from Ontario as a first introduction. And we see the differences in the lineages already, the diversity already, and likely associated with diversity that already exists internationally. So anyway, so we've been monitoring these lineages that were generated over time to determine its evolution for the purpose of communication with public health. But how do we actually communicate that with public health? We were translating these clusters into reports, outbreak reports that public health had requested. And this was required complex interpretation of phylogeny and genomics data by our technologists, and not straightforward to do. We wanted to bring these tools directly into the hands of our public health colleagues. So we collaborated with our colleagues at SFU, as well as our bioinformatician internally here, developed a tool that was able to create cluster codes automatically. So these little square histograms here are lineages over time, and the frequency is shown associated to the health authority. And so the lineages, and so you can zoom in on any of these lineages to have a closer look at the evolution of these lineages over time in a histogram format, which public health understands quite readily. And so this has just been finalized recently, and we're rolling it out to public health. We'll be able to put out these cluster codes into the hands of public health, sort of as a designation for public health and for our end users to be able to analyze the data on their own initially. And where there's an interest to dive deeper into the phylogeny relatedness, then we can follow up with a more deep dive and support the interpretation. And so,
Linda,
yes.
5 minutes.
Okay, thank you. And so this has been automated, and it allows the much faster, much more frequent dissemination of information, as well as getting the cluster codes to our end users and allowing them to do the analysis. And so around the same time, I had mentioned that prior to COVID, we had developed Plover, and Plover was implemented and quickly over a period of a few months became a major source of information for our public health. And it's been turned on. It was meant to be an interim solution, and it is now over 25 million records with about 600 active users who are actively accessing information for VOCs as well as COVID. Data linkages is extremely important for the success of genomics work. It's something that the laboratory historically has not been able to do. However, with the work in BC and the support within BCCDC, we're able to link in real-time automated quality assured laboratory data with EPI as well as laboratory metadata in real time, and allowing access for all users within public health within BCCDC. And this allows us to generate graphs like this, which I'm sure Ontario is also doing, but in a very much automated and real-time manner, allowing us to look at cases in real time, reinfections and clusters. And then finally, I think what's also really important from a laboratory perspective is how do we translate this information and share it with our colleagues in an organized way? So we developed a WGS request form that our front-end users could access, provide the information about their cluster, the line list of the patient's name and the purpose of the investigation. So is this for the purpose of reinfection? Is this for the purpose of infection prevention and control, response, a community-based outbreak, etc. And based on this initial request, we push this through our workflow. So the samples are then received, sequence, lineage assignment, we incorporate into phylogeny tree, and perform our clade assignment, and then the report is generated. And so this workflow is now fully operated and performed by our technical staff with scientific and clinical oversight. The report that we provide back to our end user has 4 components. And the components are the executive summary, a line list, a tree, a phylogeny tree, as well as an appendix. And so that is, again, also automated. It allows our end users to be able to use this, but with the implementation of the cluster codes, as I mentioned, we'd be able to reduce these outbreak requests reports and be able to focus only on those where there needs to be a scientific deep dive into the phylogeny tree. So what's been the role of genomics in our current phase of the pandemic? The role has been to support the transition from detecting variants to surveillance of variants, targeted surveillance of specific populations, hospitalization, outbreaks, breakthrough cases. And with Omicron, we will be expecting, again, a significant increase in our cases. And we need to rethink again, how do we transition from sequencing 100% to a surveillance-based strategy for whole genome sequencing as we're moving more into an endemic stage with COVID. So I want to give kudos to people. Without people, we won't be able to do the work that we've been able to do. Machines and computers are fantastic, but without the technologists, the scientists, bioinformaticians, and medical microbiologists at our facility, we would not have been able to perceive the end where we are right now. And one of the mottos that's been circulating amongst us that we all really like, and also acknowledging the research work that allowed us to pivot from a research to routine automation when the pandemic emerged so quickly, was just that we had a foundation to work from. And so today's research is tomorrow's healthcare. And the pitch here is that, we need to ensure that there's resources dedicated to ongoing research. Genomics is now standard of care, standard of practice for public health environment. The next tool that emerges continues to need to be supported from a research and development and a curiosity perspective, and then a transition over time to healthcare. And I'd like to acknowledge all the people, and I'm sure I'm still missing a whole bunch more, that have been really integral in the work that I've presented today. And although it's a very high level work, you can imagine the depth and the scope of work that was pulled together in order to provide the material that I'm able to present today as a speaking head to the BC Public Health Laboratory and our colleagues. So with that, I want to thank you for your time.
Okay, Linda, you were able to go through more than 90 slides in 45 minutes. That is almost as amazing as the number of samples that you are sequencing in the lab. It's huge. And that, okay, I will start with a question that is in the QA pod. They say, can you go back and explain the screening approach more later? Which test aspect of the genome were screened for? This is the first part of the question. The second part is, it's not entirely clear why screening was stopped. Could it not assist in weeding out samples that did not need to be fully sequenced? But in some ways you answer that at the end, no? Because you were going up and down in the number of samples that you were.
Yeah, so VOC screening was one of the first strategies we had implemented to manage the high volume of samples that was coming in. And it was really clear to us that, the sequencing strategy and the surveillancing strategy and the VOC versus non-VOC sequencing strategy that was implemented was useful at the time, but there was a lot of labor put into going back. Oh, what about that case? Oh, we haven't screened those cases. They're part of this cluster. They're part of this outbreak. And so there was a lot of going back to digging out samples that were not sequenced to support public health requests for acute care outbreaks or facility-based outbreaks. And as the numbers were going down, as we were pushed to increase our throughput and our capacity, we were able to generate the capacity to do more whole genome sequencing. And it made more sense to sequence more and to put less resources into picking and choosing samples for sequencing. That was very labor intensive and time consuming.
Okay, yeah. I have one question. You are the only laboratory in BC that is doing whole genome sequencing of COVID-19? All this number of samples that you mentioned at the end, 4,000 per week, you are doing all of them.
Yeah.
And you don't have a network that is working with you. Wow, amazing.
No, that's in, there certainly is a vision for a decentralized program in BC, but we just don't have the time and the capacity to initiate that yet. There are some laboratories that are starting to play around with whole genome sequencing from an exploratory perspective, And the long-term goal is that we would be able to integrate this provincially. But at the moment, we're producing all the genomics information.
Okay. Another question. You didn't mention, you mentioned a lot of clinical samples that were sequenced in the lab, but are you using the approach of sequencing environmental samples for predicting the dissemination of the virus in the area, like wastewater?
Yeah, so what I focused on was purely clinical sequencing. The wastewater program is independent of this. And yes, we are doing, there is a very robust wastewater surveillance program as well. It's still very much on the research collaborative with the frontline side of things. And it's being implemented more formally as we speak. My colleague Natalie Pristojecki is leading that project with our BCDC EPI colleagues as well. And it's being evaluated to monitor university areas and various other health authority regions at the city level. And we're seeing that it's able to detect, emergence of, it's aligned with the emergence of lineages that we're seeing from the clinical data from the same community, distributed by the same community.
Okay, yeah, it's clear. Have another one. You at the beginning mentioned that you had the capacity of sequencing by both Illumina and Nanopore. But at some point you mentioned that you just choose Illumina and that's it. But at this point, are you just using Illumina or you added Nanopore too?
It's a really good question. So the initial work on Nanopore was a research collaboration with UBC and with Kankojin. And so that was, took off when COVID took off while the bacteriology laboratory was building up its capacity to do Illumina. So the two was occurring in parallel, by early 2020, the two was occurring in parallel. We stopped the Nanopore workflow and transitioned fully to Illumina because it was a lot more efficient and the throughput was in place and it was also operationalized, whereas the Illumina workflow was not operationalized. It was still in the research capacity, and handling samples on an individual basis without an operational framework is extremely challenging. There were errors there was a lot of confusion in the Illumina workflow because it wasn't set up the way that the Illumina workflow was. So that's why I focus on the importance of an operationalized framework for ramping up the workflow. We have more recently looked into a parallel Illumina workflow for stat requests. And it just so happened that once, we were able to just validate that with John Tyson, one of our new scientists, that Omicron emerged, and we were able to put the potential Omicron high risk cases onto the MinI and the Nanopore workflow and be able to generate a result within hours. And so our first couple of cases, there's an outbreak in one of our universities that was flagged. We ran that through the Nanopore and was able to confirm that it was Omicron within a few hours. So that was extremely valuable for a stat workflow. The numbers have increased to the point, and our efficiency and our turnaround time for the Illumina workflow is at the point right now where operationally it doesn't make sense for us to manage two on a daily basis. And so we've stopped the Nanopore workflow for truly stat requests, and we're putting all of our resources right now into reducing the turnaround time for the Illumina workflow.
Vanessa, I think you have some questions.
Can I ask a question? Thank you, Linda. That was amazing. I am so impressed by your flow, your volume. And I know you only gleaned over this really quickly, but as a laboratory person and also not directly involved in WGS, but appreciate all of the hard work that it requires to get it going. I was wondering if you could just give like a really brief summary of the old method versus the new method and how you're able to achieve all those gains and efficiencies.
So I think a lot of it is focusing on a modular workflow by the shifting the staff schedules. Automation is huge. So, where there's people pipetting, so we were looking at, okay, what part of the workflow can we replace with a robot? And that was actively looked at. And we had some amazing technologists who were able to just jump in and program these robots, the Eppendorfs, to be able to do thousands and thousands, of samples at a time. And so that was really key, is to get the automation into place and then to set up a workflow that was streamlined, that was not linear. And that was also really key, is that each stage of the genomics process has to be independent. And so you can create multiple libraries, right? But the sequencing phase of the work has to be independent and detached from that. And so you can ramp up sequencing or ramp down sequencing depending on your volumes, but that doesn't affect your library generation. And so we're able to, depending on the situation, we're able to ramp up or ramp down any of those components. And so that was really key, is to look at the lean process and to look at it from a modular perspective, to stagger the shifts over the workflows. And we're able to even do all of this in a 5-day schedule instead of a 7-day schedule, which of course the techs wouldn't like, right? And so we also need to think about our techs' downtime. So if you have a 7-day schedule, well, they're going to be they need to take the time off during the week. How is that going to impact our regular days shifts? Right. And so we need to look at it more holistically in that way, particularly if we had a limited number of trained staff to do the work. And so it was a combination of, the operational logistics, the creativity, automation, and then optimizing on the kits. And so we're now using the P1 kits for the Illumina sequencing, which has allowed us to get results within a day, really. And so, so every opportunity to cut back time within each of the phases of the workflow was evaluated aggressively.
Okay, we have one more question and will be the last. How confident are you in using your existing whole genome sequencing pipeline to confirm Omicron, given the number of mutations that exist? Did the analysis pipeline require adjustment? What is the criteria used to base the Omicron confirmation on?
So I'll answer this on a high level, and I'll have to defer
they're very technical. Yeah, I know.
The specific technical details to my colleagues, and if you'd like the answer, I can always get back to you on that. So our initial call on Omicron, as I said, was on the nanopore. And it was through a collaboration between BCDC, specifically one of our scientists, John Tyson, with a group in the UK. And so they've already been able to identify the sequences from the UK. We compared ours against theirs, and the pipeline's already been established. It was compared against international genomics data on GISAID, on NextTrain, and with the depth of sequencing that we had, we didn't really have any problems identifying that. It was confirmed by Illumina sequencing as well. So it was a combination of both nanopore and Illumina sequencing. And it went through our pipeline without any issues.
Okay, well, thank you very much, Linda. This presentation amazed, I hope everybody, as I am. Very impressive the numbers that you showed. And not just the number of samples, but how fast you have an answer to this, the emergence of this new pathogen. And I would also like to thank everyone who joined us for today's session. It's great to see such strong virtual participation during such a challenging time for healthcare professionals. You can expect to receive the brief and anonymous PHO round survey for today's session. Please try to complete this to help us to improve our program. Lastly, to access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head the education and events, and click on presentations. Thank you, Linda, and thank you all of you, and have a wonderful day.
Thanks again for the privilege and opportunity.
Thank you, Linda, again. I just want to have some closing words. And again, Linda, recognizing this is such a challenging time for everybody in the lab and in public health with Omicron. So really appreciate your time. And you in BC with everything that's going on there as well. So really, really appreciate your time. I also want to take this opportunity to thank everyone for joining us for our 2021 session of PHO Microbiology rounds. I think we had some phenomenal speakers, and we look forward to hosting another set of phenomenal speakers in 2022. So we hope to see you again back here to join us in 2022, and wishing you all a very safe and happy holiday season.